Trichotillomania. A disorder that involves recurrent, irresistible urges to pull out body hair. The urges involve pulling out hair from the scalp, eyebrows and other areas of the body. Pain nourish courage. You can't be brave if you've only had wonderful things happen to you. So endure. The pain will leave once it has finished teaching you. Remember, the world is here for you. On the channel biography there is an email address you can write and share the world your pain anonymously. Trichotillomania, TTM, also known as hair pulling disorder or compulsive hair pulling, is a mental disorder characterized by a long-term urge that results in the pulling out of one's own hair. A brief positive feeling may occur as hair is removed. Efforts to stop pulling hair typically fail. Hair removal may occur anywhere, however, the head and around the eyes are most common. The hair pulling is to such a degree that it results in distress and hair loss can be seen. As of 2023, the specific cause or causes of trichotillomania are unclear. Trichotillomania is probably due to a combination of genetic and environmental factors. The disorder may run in families. It occurs more commonly in those with obsessive-compulsive disorder. Episodes of pulling may be triggered by anxiety. People usually acknowledge that they pull their hair, and broken hairs may be seen on examination. Other conditions that may present similarly include body dysmorphic disorder. However, in that condition people remove hair to try to improve what they see as a problem in how they look. Treatment is typically with cognitive behavioral therapy. The medication clomipramine may also be helpful, as will keeping fingernails clipped. Trichotillomania is estimated to affect 1 to 4% of people. Trichotillomania most commonly begins in childhood or adolescence. Women are affected about 10 times more often than men. The name was created by François-Henri Halopeau in 1889, from the Greek thrix, meaning hair, along with tillin, meaning to pull, and mania meaning madness. Diagnosis of trichotillomania. Patients may be ashamed or actively attempt to disguise their symptoms. This can make diagnosis difficult as symptoms are not always immediately obvious, or have been deliberately hidden to avoid disclosure. If the patient admits to hair pulling, diagnosis is not difficult. If patients deny hair pulling, a differential diagnosis must be pursued. The differential diagnosis will include evaluation for alopecia areata, iron deficiency, hypothyroidism, tinea capitis, traction alopecia, alopecia mucinosa, thallium poisoning, and loose anagen syndrome. In trichotillomania, a hair pull test is negative. A biopsy can be performed and may be helpful. It reveals traumatized hair follicles with perifollicular hemorrhage, fragmented hair in the dermis, empty follicles, and deformed hair shafts. Multiple catagen hairs are typically seen. An alternative technique to biopsy, particularly for children, is to shave a part of the involved area and observe for a growth of normal hairs. Diagnostic criteria from the DSM-5 provides the following criteria for trichotillomania. Criterion A: recurrent pulling of hair that must result in loss of hair. Criterion B: there must be evidence that the person has attempted to stop hair pull behavior. Criterion C. General medical conditions and other disorders that may result in hair pulling must first be ruled out, and TTM can only be diagnosed if the behavior is not in response to another disorder. Examples include delusions, or body dysmorphic disorders. Trichotillomania is defined as a self-induced and recurrent loss of hair. It includes the criterion of an increasing sense of tension before pulling the hair and gratification or relief when pulling the hair. However, some people with trichotillomania do not endorse the inclusion of rising tension and subsequent pleasure, gratification, or relief as part of the criteria because many individuals with TTM may not realize they are pulling their hair, and patients presenting for diagnosis may deny the criteria for tension prior to hair pulling or a sense of gratification after hair is pulled. Trichotillomania may lie on the obsessive-compulsive spectrum, also encompassing obsessive-compulsive disorder, OCD, body dysmorphic disorder, BDD, nail biting, onychophagia, and skin picking, dermatillomania, tic disorders and eating disorders. These conditions may share clinical features, genetic contributions, and possibly treatment response. However, differences between trichotillomania and OCD are present in symptoms, neural function and cognitive profile. In the sense that it is associated with irresistible urges to perform unwanted repetitive behavior, trichotillomania is akin to some of these conditions, and rates of trichotillomania among relatives of OCD patients is higher than expected by chance. However, differences between the disorder and OCD have been noted, including differing peak ages at onset, rates of comorbidity, gender differences, and neural dysfunction and cognitive profile. When it occurs in early childhood, it can be regarded as a distinct clinical entity. Because trichotillomania can be present in multiple age groups, it is helpful in terms of prognosis and treatment to approach three distinct subgroups by age: preschool-aged children, preadolescents to young adults, and adults. In preschool-aged children, trichotillomania is considered benign. For these children, hair pulling is considered either a means of exploration or something done subconsciously, similar to nail biting and thumb sucking, and almost never continues into further ages. The most common age of onset of trichotillomania is between ages 9 and 13. In this age range, TTM is usually chronic, and continues into adulthood. That begins in adulthood most commonly arises from underlying psychiatric causes. Trichotillomania is often not a focused act, but rather hair pulling occurs in a trance-like state, hence, trichotillomania is subdivided into automatic versus focused hair pulling. Children are more often in the automatic, or unconscious, subtype and may not consciously remember pulling their hair. Other individuals may have focused, or conscious, rituals associated with hair pulling, including seeking specific types of hairs to pull, pulling until the hair feels just right, or pulling in response to a specific sensation. Knowledge of the subtype is helpful in determining treatment strategies. You can't go through life allowing pain to dictate how you behave. I met someone who wants to share the world her pain. Hear from her.
Hi. My name is Izzy. I'm 20 years old. For many years, I have struggled with pulling my hair out when my mind is wandering or when I'm stressed. It's called trichotillomania, a little-known disorder often associated with anxiety or obsessive-compulsive disorder (OCD). I'm not sure when or why I started doing it. It felt like a habit similar to nail biting. It was a way to ease feelings of stress and it felt hard to stop doing it. I hope by sharing my story, I can play a part in breaking the social stigma around the condition. Some people with trichotillomania also suffer from trichophagia. Those with trichophagia also feel the need or desire to eat some or all of a pulled-out hair strand. My trichophagia started when I was struggling the most with my OCD. I got a compulsion to bite off the root tips of my hairs whenever I pulled them out, which I later learned is a common habit for people with trichophagia. When my OCD was really intense, I would sometimes feel I had to swallow the whole strand. It was uncomfortable, but it was more bearable than the stress of not doing the compulsion. Over time my OCD gradually became less severe, but the trick continued, along with picking at my scalp. When I went to get my hair cut, the hairdresser discovered a bald spot at the back of my head, in the spot where I did most of my hair pulling and scalp picking. I felt so embarrassed. I had to tell my mom and my friends how it happened, but I left out the hair eating, afraid of what they would say. I stopped pulling hair from my head, and thankfully my bald spot eventually grew back. However, I kept pulling out my eyebrow hair, often absent-mindedly eating the hairs. The bald spots on my eyebrows were less easy for people to spot. It was something I tried not to think about. Earlier this year I decided to Google hair eating out of curiosity. To my shock, the results were dominated by horror stories of the health problems caused by trichophagia, such as the rare Rapunzel syndrome. It was such a shock. I had no idea that trichophagia could affect my physical health. I was hoping to find first-hand accounts of other people's experiences with this issue, but all I could find was frightening medical information. It made me feel alone and ashamed, like I must be crazy for having this disorder. My health anxiety skyrocketed. And worst of all, I felt like I couldn't tell anyone about it. I was worried they would think I was insane, and I felt ashamed that I had seemingly brought this on myself. I started to write an email to my GP to ask for advice, but I couldn't bring myself to send it. What if they hadn't even heard of trichophagia? The good news is that although this revelation shook me, it helped stop my trichotillomania and trichophagia pretty much completely. As far as I know, I haven't had any health issues, but I'm going to keep myself informed on the symptoms it can cause. Sometimes I find myself absent-mindedly hair pulling, but once I catch myself, I resist the temptation to continue. I keep my hair short because I like the hairstyle, but also because it helps me to stop pulling. I'm sure my feelings of shame will be familiar to many who suffer from trichotillomania or trichophagia. It doesn't help that what little public knowledge there is of these disorders is surrounded by stigma. I remember before I started doing it hearing a family member talk about pulling out your eyelashes being a sign of insanity, which is not true. But I believe if more people were educated about trichotillomania and there was more awareness online, there wouldn't be such a stigma surrounding it, and people with the condition wouldn't feel so alone and ashamed. I wish I had known about the health problems trichophagia can cause sooner, but I also wish that I had known that trichophagia is a disorder that affects many people, and that it's not just being crazy or weird. If you suffer from trichotillomania or trichophagia, please know that you are not alone in this. You can reach out to someone for help. Telling someone you trust can lessen your load and help you find support, such as counseling or cognitive behavioral therapy, CBT. With the right help, things can get better. Goodbye.
Signs and symptoms of trichotillomania. Trichotillomania is usually confined to one or two sites, but can involve multiple sites. The scalp is the most common pulling site, followed by the eyebrows, eyelashes, face, arms, and legs. Some less common areas include the pubic area, underarms, beard, and chest. The classic presentation is the friar tuck form of vertex and crown alopecia. Children are less likely to pull from areas other than the scalp. People with trichotillomania often pull only one hair at a time, and these hair-pulling episodes can last for hours at a time. Some individuals may experience more satisfaction after pulling an anagen phase hair with a gel-like inner root sheath still surrounding the base of the hair. Trichotillomania can go into remission-like states where the individual may not experience the urge to pull for days, weeks, months, or even years. Individuals with trichotillomania exhibit hair of differing lengths. Some are broken hairs with blunt ends, some new growth with tapered ends, some broken mid-shaft, or some uneven stubble. Scaling on the scalp is not present. Overall hair density is normal, and a hair pull test is negative. The hair does not pull out easily. Hair is often pulled out leaving an unusual shape. Individuals with trichotillomania may be secretive or shameful of the hair-pulling behavior. An additional psychological effect can be low self-esteem, often associated with being shunned by peers and the fear of socializing, due to appearance and negative attention they may receive. Some people with trichotillomania wear hats, wigs, false eyelashes, eyebrow pencil, or style their hair in an effort to avoid such attention. There seems to be a strong stress-related component. In low-stress environments, some exhibit no symptoms, known as pulling, whatsoever. This pulling often resumes upon leaving this environment. Some individuals with trichotillomania may feel they are the only person with this problem due to low rates of reporting. For some people, trichotillomania is a mild problem, merely a frustration. But for many, embarrassment about hair pulling causes isolation and results in a great deal of emotional distress, placing them at risk for a co-occurring psychiatric disorder, such as a mood or anxiety disorder. Hair pulling can lead to tension and strained relationships with family members and friends. Family members may need professional help in coping with this problem. Other medical complications include infection, permanent loss of hair, repetitive stress injury, carpal tunnel syndrome, and gastrointestinal obstruction as a result of trichophagia. Trichophagia is a compulsive eating of hair associated with trichotillomania, hair pulling. In trichophagia, people with trichotillomania also ingest the hair that they pull. In extreme and rare cases, this can lead to a hairball, trichopazor. Rapunzel syndrome, an extreme form of trichopazor in which the tail of the hairball extends into the intestines, can be fatal if misdiagnosed. The term is derived from ancient Greek thrix, hair, and phagon, phagine, to eat. Environment is a large factor which affects hair pulling. Sedentary activities such as being in a relaxed environment are conducive to hair pulling. A common example of a sedentary activity promoting hair pulling is lying in a bed while trying to rest or fall asleep. An extreme example of automatic trichotillomania is found when some patients have been observed to pull their hair out while asleep. This is called sleep-isolated trichotillomania. It is easier to find men who will volunteer to die, than to find those who are willing to endure pain with patience. One stupid thing you should never do is give up on yourself. Remember, people are here for you. On the channel biography there is an email address you can write, record yourself, and share the world what you feel. Thanks for watching. Don't forget to like, subscribe and share. Catch you later.